Okay, thanks, Vito. Thank you, all the staff, for helping us tonight. We're very proud to be back on our National Hispanic Medical Association COVID-19 virtual briefing series. And today we're going to focus on veterans and telehealth and also health literacy. I'm Dr. Elena Rios, President and CEO of the National Hispanic Medical Association. And we have a great lineup of speakers who I will introduce one at a time. Tonight we have Spanish translation for those in our family who would like to listen to the program in Spanish, and I'll give you more details about that. We have some Zoom polls and live translation, as I mentioned, only in Spanish. We have, we'd like all the participant microphones to be muted, but feel free to use the raised hand feature to be unmuted if you'd like to ask a question, or type your question into the Q&A box for the panelists to address those questions at the end. And the Q&A box is not the chat box. We like to use the chat box internally in case there's an issue for the panelists. We would also like you to fill out the short post-webinar survey that will be emailed out right after the event. Raffle prizes are going to be available upon completion of that survey. And the recording of this webinar will be hosted on our NHMAMD.org website and sent out a week after the event, along with instructions to claim your CME. This is CME for providers. Next slide. We have our learner notification on the CME from Amedco. We have no disclosures to discuss. Next slide. And this is a slide to show how to activate your interpretation. Next slide. Okay. So the interpretation is a word. You have to click on the word interpretation where you see the globe icon on your screen. And then you select the language that you're most comfortable in listening to. We will have English and Spanish. You can also click mute original audio if you only want to hear the interpreter's voice. So next slide. So we're very honored to have as our co-sponsor today the American Medical Association. And with us is the president of the American Medical Association, Dr. Gerald Harmon. I just want to say a few words about him. He is a family medicine physician from South Carolina who's been there over 30 years as a clinical professor at 2 medical schools, and also is the vice president for a multi-specialty physician practice, and also teaches residents. And more importantly for today's event, he is from the Air Force, and was in active duty and in the Air National Guard, and retired as a major general. He has, I think, very important experiences to tell us. So Dr. Harmon, why don't you go ahead and start your presentation?
Dr. Rios, thank you very much. I'd like to express my sincere appreciation for the collaboration, the invitation to participate. And it means so much that the NHMA would work, allow us to be collaborative and provide some perspective and comments on this distinguished panel this evening. Thank you very much. If you give us the next slide, I'd appreciate it. One of the things that we've done with this pandemic is we found how important organized medicine is. We have the tremendous power and the influence of physicians and the voices of the NHMA and the AMA to deliver things that would be very difficult for us as individual physicians or practices. So what the AMA and collaborative partners such as the NHMA have done is we've tried to be a trusted, peer-reviewed, evidence-based resource for clear guidance to physicians and to patients and to regulators about how to handle the COVID-19 situation. When we're doing that along with asking the government, and they've responded very favorably and giving us some economic relief as we struggle to keep our practices, our hospitals, our healthcare institutions open in a economic stresses of a COVID world. They've been very good at that. We've also been advocating for protective equipment for our providers and for equitable availability of the vaccines and the treatments for it. So they've been very responsive. But one of the ways we've done that is with the voice of organized medicine. One of the things we've also worked with is trying to advocate for science-based evidence reviewed and peer-reviewed policies that would be equitably distributed, that would help us with testing and vaccine development and distribution, and for treatment modalities. And all of that's been part of our guiding arc here in the pandemic. Next slide. One of the things that there is, if there is another silver lining, in addition to recognizing the value of organized medicine, is that we've got this thing called telehealth that we just have learned how to utilize and are continuing to learn how to utilize in the pandemic. It's been incredible how valuable it is for us as physicians and as providers. You know, physicians, 90% of doctors are now using telehealth, and they didn't only about 50% of them did it before. So we've doubled the number of physicians using telehealth. Patients are overwhelmingly supportive and happy with it. It's been an incredible lifeline, not only for physician and provider practices to stay open, including the VA, but it's been a lifeline for patients who had difficulty getting to medical care prior to the pandemic, and certainly in the pandemic, because of concerns of their own health and safety. This has been a very valuable tool. So what we've asked the federal government to do is to extend these changes that were made during part of the public health emergency with telehealth delivery and compensation and regulatory management, to extend that well past the end of the COVID pandemic, and they've been very supportive. There are several legislative efforts that we're advocating for at the federal and state levels that will allow our patients to continue to receive health care from the comfort and safety of their own home, and particularly to expand connectivity, so that if you don't have broadband, internet, or even wireless telephone, mobile telephone communications, and in my rural neighborhood, there are places where you just don't have cell phone coverage, and you sure don't have wide broadband coverage. So you really have to try to make sure we get that into our rural underserved areas where a lot of our marginalized patients do live. So that will help improve that social determinant of health for sure, if we can get that initiative supported as well. A lot to do. Next slide. Now, in addition to asking the government and the federal government and the legislators to support telehealth, we've got to teach ourselves how to use it. You know, I mentioned that of the 90% that are using it now, 50% didn't use it before. So they've had to learn how to do it. We're providing online at our AMA website a bunch of electronic resources, including CME credit that you can get if you go through some modules, some digital modules. We're trying to teach our residents and physicians how to do it. We're working with a couple of state medical societies around the nation to try to find out some best practices, so we can then translate those best practices into other pilot programs for other state organizations. We actually have a digital health implementation playbook on our online website. I've looked at all this stuff, and as a country doctor in family medicine in rural South Carolina, I find it very beneficial for me. It tells me how to set it up, gives you some advice on how to ask questions appropriately. It allows me to understand the economics of how to put the CPT codes and things in. So it really gives us a good chance at continuing the example of telehealth as one of our operational constraints that we can use in the delivery of healthcare. A real good, important access and teaching point for the AMA. Next slide. The mission statement of the AMA is to advance the art and science of medicine and betterment of public health. That second part of that mission statement is near and dear to me as a physician and as president of the AMA. We can't advance public health unless we address health equity. We're committed as part of our mission statement and as part of our code of ethics to achieving health equity. You'll see on this slide that the two key principles in our code of ethics is that we're providing competent medical care with compassion and respect for human dignity and rights. We are to respect the law, but recognize our responsibility to seek changes when it is contrary to the best interest of our patients. Non-discrimination, health equity, and access to health care for all are key goals of our advocacy work. Next slide. Within the AMA itself, at the House of Delegates, we have the Minority Affairs section, which we call the MOS. It is a very long duration Minority Affairs section. It has key influences at the federal and national level. Dr. Rios and I had a conversation before we went online that the NHMA has a slotted seat on the Minority Affairs section. I'm a member of it myself. I've been a member for a decade. It is critical that the Minority Affairs section has an active voice within our House of Delegates. And one of the neat things it does within its active policies and programs, it has a Doctors Back to School program that increases diversity among underrepresented marginalized physician communities. And it really is incredible how effective these doctors back to school programs. I participated in 4 or 5 of them across the United States. We go out into elementary schools, to middle schools, and we tell these young kids who represent a huge diverse population that they can be members of the healthcare community. We like for them to be doctors, but if they want to be physical therapists, pharmacists, registered nurses, things like that, anything that opens their opportunities and sees, and they get to see the people that look like them can have healthcare jobs. And it really is something they may not see otherwise in their neighborhoods and then their current educational background. So this is critical for those kind of outreach programs to improve the diversity of our workforce. Next slide. What we have done, we're trying to put our words into action. This past May in 2021, the AMA released under our Center for Health Equity, a strategic plan to embed racial justice and advance health equity. 5 pillars, I'll read them real quickly. It's to embed equity in the AMA itself. We're going to build alliances and share powers with stakeholders such as the NHMA. We're going to ensure equity of innovation, such as telehealth and digital health, to make sure it crosses all patient populations. We're going to push upstream to address the social determinants of health so we can find out who's fallen in the river. So when we try to rescue them downstream, it's a whole lot better to go upstream and get people to not jump in the river, fall in the river, so we don't have to do so much rescue ops. And finally, we're going to foster truth, reconciliation, and racial healing and transformation within the AMA itself. So that's an important 5-pillar program. Next slide. One of the things we're having to do is not only produce this document and then have a 3-year strategic plan, we've got to educate our doctors, especially our younger physicians and older physicians like myself, about what we're trying to do. You got to understand the problem and you understand the vehicle we have for it. And so we have on our educational hub several different educational initiatives where you can go, members and non-members alike, can try to you get online, look at our various learning modules and learn more about it, and then figure out how to, you as an individual healthcare provider can be participatory in part of the solution and make this work. Next slide. On the heels of our strategic plan to advance health equity, this past fall, we came up with a language document, a narrative document that isn't about word policing, but about increasing the awareness of how words matter, how it's so important to get them right when you're trying to establish trust, two-way communication, and make sure that you can convey as a healthcare provider, we as healthcare providers, to our patients, and they to us, their needs, their desires, and have it a clear two-way method of communication. Our goal is to center healthcare around the lived experiences of people and communities without reinforcing labels. A clear example, and I'll just tell about it. I had a conversation 2 days ago with one of my residents in the office. She came to me, she's an intern. She said, Dr. Harmon, let me describe this as a 32-year-old alcoholic that's here to have their blood pressure checked. And I said, time out. This is a 32-year-old female who's here to have her blood pressure checked. If you want to mention her past medical history, that she has a history of recovering alcoholism or substance use disorder, you can mention that. But I don't want to have that label that this is the 32-year-old alcoholic. And she said, I had thought about it. I said, well, it's part of my job is to teach you what we need to do so we don't stigmatize people. And we understand that she's in recovery. It is part of her healthcare plan and her current situation, but let's don't prejudge her that way. It means a lot to me, you can tell. Next slide. What we have is a lot of concerns about our Latinx Hispanic families for sure. We have every intention to focus on improving that. The slide here talks about 17% of Hispanic adults are in fair or poor health, no question of it. Next slide, and this will be my final one. I'd like to show you that what we're also doing is we're focusing on health care for our U.S. veterans, okay? Those that have served our country deserve the highest quality care. I'm the father of a combat veteran in Afghanistan. I myself am a combat veteran from Iraqi freedom, enduring freedom. My father was my deceased father was a Korea veteran. My mom is a widower of a World War II veteran. So we're all about veterans health care. I'll answer questions later on as we go on, but I have so much to talk about. I'm looking forward to be part of this conversation. Thank you.
Thank you. Next, well, before I take the next speaker, just want to be sure that the speakers talk a little bit more slow for the interpreter. and also that everybody can ask questions, but put your questions in the Q&A box and our speakers will answer after they finish. So the next speaker is Colton Whitaker, Director of Programs for the Elizabeth Dole Foundation. He is a manager for the Campaign for Inclusive Care, and he's been with several different organizations in the DC area. One is called the Center for American Progress, and he also worked with Congresswoman Giffords on gun violence. And he has his degrees in political science and business from Texas A&M. Colton?
Hi, yeah, definitely. Thank you, NHMA and Dr. Rios and Vito and the team for inviting me to participate. I'm so honored to be alongside these distinguished panelists. And Dr. Harmon, thank you for your service and for your time. As mentioned, my name is Colton Whitaker, and I am a Director of Programs at the Elizabeth Dole Foundation. I am super excited to share a little bit more about our efforts in really promoting a more inclusive model of care, and specifically around veteran caregivers. If you go to the next slide. So I like to just start things off, with a little bit about our foundation to kind of set the tone, and I think really helps provide context for what caregivers face and really what the pressing needs and the seeds of the Elizabeth Dole Foundation, which were really planted back in 2011 when Senator Bob Dole spent 11 months at Walter Reed National Military Medical Center here in the DC area recovering from surgery. His wife, Senator Elizabeth Dole, at the time met countless of individuals caring for family members that were wounded in war, and she was deeply moved by their challenges, their stories, and just a lot of the things that they shared with her during that time. As a direct result from that experience, the foundation came to be. And today the foundation is the preeminent organization empowering, supporting, and honoring our nation's military caregivers, those who are voluntarily caring for America's wounded, ill, or injured veterans at home. Our foundation's mission is to strengthen and empower American military caregivers and their families by raising public awareness, driving research, championing policy, leading collaborations that make a significant impact on our hidden heroes and their families around the country. We really envision an America where military caregivers are empowered, appreciated, and recognized for their service to our nation as well. Senator Dole, and I want to mention this to kind of also set the tone, one of Senator Dole's top priorities after forming the foundation was to commission the RAND Corporation to really develop the first of its kind comprehensive evidence-based national study on military and veteran caregivers. If you go to the next slide, really some of the key components that this RAND study found that there are 5.5 million military and veteran caregivers serving across the nation who are offering $14 billion worth of uncompensated care. These are the spouses, the family members, and in some instances, neighbors or even children who are, offering, care in one capacity or another. And unfortunately, this report came to tell us that these individuals are experiencing great physical, emotional, and family strain, and unfortunately are often facing these challenges alone. This report also went to highlight that many caregivers are the frequently and sole breadwinners of their families, and most are balancing the responsibilities of managing a household, childcare, legal and financial challenges on top of many of the complex medical conditions of their care recipients. We went on to realize that this results in higher rates of anxiety, depression, and other deteriorating health for caregivers themselves, obviously on top of the issues that they're, in our instances, veterans or even other loved ones may be facing. So if you go to the next slide, I want to mention as well that, at the same time as really doing a lot of research for the first of its kind within this hidden hero in military and veteran caregiver population, we also wanted to delve even deeper in the caregiver journey. And what does that mean specifically for caregivers? And so in 2014, we also partnered with the U.S. Department of Veterans Affairs and worked directly with caregivers to develop an experience map to help identify areas of highest vulnerability for veterans, service members, caregivers, other members of their family over the course of their lifetime. And, really some of the major findings from this was really those initial clinical visits for caregivers, those initial moments where they're realizing I am a caregiver, or I am, taking on those additional responsibilities is such a vulnerable point, but is also such a critical point to making sure that we're having that inclusive, collaborative care team from the get-go. And so as a part of this initial work, we recognize that the most vulnerable point identified by many caregivers were those initial clinical visits for their loved ones. For many, these initial clinical visits were the first time that the caregiver was maybe not a part of a conversation or, not a part of their loved one's care journey whenever they return back from their service. This cascading effect from those initial visits often extended throughout that patient's care, leading to many missed opportunities. Readmission rates were high, increased costs and frustrations just throughout that caregiver's journey. So after our research with the RAND report and really delving into the issue at hand, speaking with caregivers, speaking with families, speaking with clinicians and care teams, we recognized that this was an issue we wanted to get to the bottom of. And if you go to the next slide, we further elevated this further by actually interviewing and doing a little bit more understanding of what are those challenges and what are the opportunities in this phase. And during this time, we interviewed caregivers, asking them, simple questions from their experience. And, the idea of healthy communication between a healthcare team and caregivers is so vital, setting that tone for engagement and setting that tone for those positive health outcomes. And I think it shows that here. Just for a little bit of context around this, we surveyed caregivers within our sphere and asked, what does your engagements look like with your veterans care team? And the results here show that 56% of the time, they were never asked, the caregivers were never asked for their ideas about managing their veterans' health. Additionally, 69% of the time, whether they have the skills or even training that they need to better help with their veterans' care or what's being asked of them. And then additionally, a little over 70% of the time, if they needed help at home or in their settings in managing their loved one's health conditions. And so, I think this really elevated that there was a clear disconnect when it came to VA caregivers in their engagements with their loved one's care team. If you go to the next slide, we also wanted to ask caregivers, okay, so we recognize that these numbers might be high. We recognize that you might not be having that solid communication and collaboration, but why do you feel that might be? And this slide really talks about some of the barriers that caregivers thought may exist. Lack of time by the medical staff. They can't deal with me because they're dealing with the veteran or the patient. Additionally, I'm not a provider. I don't know all the details. That might be represented as well. Additionally, a very common one that we heard often were legal and privacy concerns. That understanding of what can I share, what can't I share, can I be a part of X conversation and so forth. And then additionally, the care team may not even know that I'm a caregiver at home. I'm caring for my loved one. So in recognizing a little bit more of these stats and some of these barriers, we at the Elizabeth Dole Foundation, in partnership with the VA, really wanted to delve into, okay, what can we do to really start building that more inclusive care team that is more inclusive of caregivers, and why is that needed? And if you go to the next slide, this provides a little bit of a summary of why. So I shared a little bit about that RAND study back in 2014. And, based on those findings, we believe that the best chance for a wounded warrior to recover and thrive is having that strong, supported caregiver. Additionally, as I mentioned during that care journey, one of the most vulnerable points for those veteran caregivers are those initial clinical visits, where that communication and collaboration can be challenging, if not done initially from the start. Additionally, the caregivers providing most of that care outside of those hospital walls, so their input understanding is critical. for those improved patient outcomes that may come about. And then lastly, we know, through our work that inclusive care improves outcomes, experiences for caregivers, patients, clinicians, and, helps limit clinician burnout as well. So if you go to the next slide, it kind of just breaks this down a little bit further into, into what I kind of just said of, really this inclusive care model is that system-wide approach to care that embraces, engages, and empowers caregivers, clinicians, veterans, and the whole care team throughout that care journey from day one, from that very first interaction of when that care journey starts. We know that inclusive care increases the capacity and competency of the entire care team to deliver appropriate, efficient, effective, and high-value services. It improves health outcomes, relationships, and quality of life, and supports that system-wide performance. It's truly team-based, with care being that partnership amongst the clinical care team, family caregivers, and the others as well. It's really centered around, as I've said before, that sound communication and secure feedback and collaboration from all care partners as well. So, after breaking down a little bit of this summary, and if you go to the next slide, we worked and developed our campaign for inclusive care, recognizing that, if we want to really change culture, if we really want to make sure that caregivers are starting to be included, starting to be talked about, starting to be recognized and empowered, we need to have a campaign around this and really make sure that messaging is moving forward around the care spectrum. So we developed the campaign for inclusive care in close partnership with key subject matter experts from the U.S. Department of Veterans Affairs, and really was founded, this evidence-based framework to support this multi-year enterprise-wide implementation of the campaign across the VA system. So this is something that we're currently doing as a quality improvement effort across the VA, but recognizing a lot what we're learning and a lot of the techniques that we're training on can be translated across the spectrum, whether you're inside the VA or not, or whether you are a veteran or not. So kind of delving a little bit more into this here, as we initially developed we chatted a little bit earlier about, training modules. We also helped develop our campaign academy for inclusive care, which is a series of educational resources tailored for clinicians, healthcare staff, just general staff that may work in the healthcare setting, to really help elevate, this topic and issue forward. These video training modules that you can see the topics listed on this slide are moderated by Dr. John Torres, who's the chief medical correspondent for NBC News. He's also a veteran himself, which really provide that step-by-step instructions and consistent messaging and guidance on how best we can integrate caregivers into care teams and start to talk about the roles that they can play. These topics were a direct result from visiting sessions with VA stakeholders, social workers, physicians, nurses, OTs, PTs, everybody across the board recognizing, okay, what can we best do to at least start the conversation with our peers, with our colleagues? And these were the topics that they recommended were around just the ideas of what is inclusive care. Who are military caregivers? Many folks said there's a lot of our peers who don't even recognize that there's maybe caregivers that are taking care of their patients when they go home. There's other folks involved. So how can we best translate that? Additionally, communicating with the caregiver. I mentioned one of the key barriers that caregivers were thinking of were privacy concerns. So that's also something that's on the provider side, privacy concerns, which is definitely fair. So how can we best start that communication? What tools can we provide? What messaging points can we provide to folks so that they are starting to bridge that, that communication divide? And then lastly, understanding that caregiver journey. I mentioned the caregiver journey map on earlier slides, recognizing that each caregiver journey is unique. It's going to be different from one caregiver, from one patient, from one family to the next. So how can we best start to recognize that and bridge that divide? So if you go to the next slide, I just have a couple more slides left, and I want to make sure I'm fine on time. But a couple key components that we've really built into our Academy for Inclusive Care training is kind of elevated on this slide here. And one thing that we've really built this around is the acronym CARE. So CARE, and we've outlined that here as consider, acknowledge, review, role, and encourage. And, we elevate that, if you don't take anything from the Academy modules, at least maybe these are some key things that you can take, very simple things that you can take and immediately put into practice. And so consider, we're encouraging folks to consider who else may need to be present. Asking the veteran or asking the patient, is there someone else you would like to have in the room during your visit? Or is there someone you rely on for support that you would like to have here as part of this conversation? We recognize that we shouldn't assume that a veteran can handle all their medical care by themselves. So we should ask those direct questions for clarity. Additionally, acknowledging. So recognizing that the veteran's caregiver has taken on that extra work and that it may impact their own wellness and health as well. So empathetic marks such as, I imagine it's such a big responsibility to take on these additional roles, or I appreciate your dedication to their health, can go such a long way when you're talking to the caregiver and the care team to really help establish that rapport and camaraderie. Reviewing the role. So determining the responsibilities that the caregiver is comfortable with. Questions for the caregiver can include what tasks are easy for you to perform, or are there any duties that cause you to feel uneasy while you're performing them? Early identification of what the caregiver can and can't do will help ensure that the veteran achieves their highest possible health and well-being. And I think reviewing this role continuously to making sure that you're up to date on where the caregiver may be in their own space is extremely, extremely important. And then the last piece that we're really elevating is encouraging, finding out if there are any barriers that exist and how you can help them overcome and make that caregiver's responsibilities easier. Simple questions, such as how can I help with your at-home responsibilities for your veteran, or what would make taking care of your loved one simpler, and really encouraging them and empowering them to seek supports that are out there. On this slide here, I encourage folks to go to the VA caregiver support line, but I know there's many other supports that are out there in regards to military and veteran caregivers and just family caregivers in general that are available as well. So if you go to the next slide, just wanted to briefly show this as well in regards to telehealth. Given the past, obviously, 2 years, as we just mentioned before, that a lot of folks moved this direction. We had to. There was pandemic, there was very much opportunities to grow in this realm. And so we kind of were elevating this forward by saying, you can still care in a virtual format. You can still make sure that you're asking the appropriate questions, considering, acknowledging, reviewing, and encouraging the whole care team that includes the veteran, the patients, the loved ones, and care teams as well. And so we really wanted to make sure you can elevate that forward, that no matter if it's a virtual telehealth clinical appointment, to really make sure inclusive care is recognized and utilized in practice from care team to care team. So if you go to the next slide, that's kind of what I wanted to wrap up. I know I threw a bunch of stuff at you talking about our campaign for inclusive care. Definitely happy to answer any questions at the end and help clarify anything that I may have shared on this topic or just broadly speaking. So thanks again and look forward to the discussion.
Thank you, Colton. I think now to really tie the program together here from both speakers focused on communication with Latino patients, we have to consider skills that we need, especially with the caregivers and especially with veterans, and especially with all of those who are affected by COVID-19, who are new to the healthcare system. Latinos need more health literacy skills. So to tell us about that is Dr. Rebecca Vargas Jackson, who's an infectious disease specialist and has been a consultant and a special subject matter expert for the not only the state of Virginia, but lots of the organizations in the DC area, and especially Howard University. She actually is a co-leader of a stigma conference on HIV/AIDS and has a lot of interest in helping develop the physicians' awareness, not only of veterans, but of all Latino patients in general for health literacy. Dr. Vargas.
Hello, everybody. And well, let me tell you that to talk about health literacy in 15 minutes is a challenge. So regularly we have 8 to 10 hours to have the health literacy 101. So I'm just going to go and present some of the scientific facts and Office of Minority Health data that emphasize in the large number of the US population with low health literacy skills. Initially, I would like to refresh our knowledge of some of the key elements that play a role in the health literacy skills of individuals and how important it is for providers to understand and assess the health literacy skills and the cultural background of their patients. This is so important that informal is being called the new vital signs. Next, please. These are some of the topics that very briefly I'm going to address: social determinants of health, equity, cultural competence, racial and ethnic diversity, bias and stigma and discrimination, because these are the pieces of the puzzle for health literacy. Next. I was reading a couple of research studies in the Veteran Affairs and the Veteran Health Administration to emphasize on the fact of health literacy. I realized that 45% of veterans are in the basic or intermediate health literacy skills. That put us in a kind of very tricky situation. And the African American community of veterans have much inadequate levels of these health literacy skills. Looking into a Chicago study talking about cancer screening, veterans with limited health literacy were the ones who could not identify colorectal cancer importance in the fetal of cold blood testing. Next, please. Many other studies are there, and I was reviewing some. Basically, African American had a lower health literacy in the veteran affairs than if we compare with the white counterparts. Unfortunately, there was not much research studies on Latino veterans on this particular topic, health literacy and numeracy. Next, please. Mention social determinants of health as a key element, because to increase health literacy skills, we were thinking in virtual, right? Like we are using so many virtual formats. But unfortunately, in several areas in the United States that they are either rural or very poor areas in the country, there is a lack of adequate broadband, no access to smartphones or laptops. So that increase the health literacy skills gaps that we have in some sectors of the population. Next, please. That was another study in veteran affairs that I was trying to highlight because that was COVID-19 related, and realizing that there were fears, one of the limiting issues for veterans in not getting vaccinated. So we need to conclude that if we increase their health literacy skills, we will increase the vaccination acceptance. The next one. We need to talk about equality and equity, because as we notice in this picture, if we give everybody equal, it's not going to work. So in health literacy, we need to work with equity, which means give people what they need according to the health literacy skills levels. Next. There are so many definitions of culture. Basically, let's go to the next, because what I was trying to say is that culture is what we are. It defines many things in health issues, like what patients and doctors believe about the causes of disease, how life and health is perceived, and who should be the provider for a problem. Maybe it's not the doctor initially. Next, please. And we can jump to the next one. And the influence that culture has over health literacy and our health is very vast. It affects how we perceive health, the causes of diseases, right? We're thinking about, hey, is the Ebola, is voodoo, or is a virus? But not only that, it defines the types of treatment we prefer. I can see here in the US that is very common when people start sneezing and talking about, oh, I need a chicken soup. Well, yeah, it's a cultural issue. Next, please. Cultural competence is very basic, and so is the ability that we have to understand, communicate effectively, and interact with people across cultures. But let's stop here, because across cultures doesn't mean people who just arrived to the US or is limited English proficient. I'm talking about culture inside of your own families. Grandfather's family culture is very different from our kids' culture. So let's start thinking in that way when we are talking cross cultures. Next, please. The continuum of this cultural competency spectrum, it was here just to show us that this is not a destination. It's going to be a long journey that we need to explore day after day with our different patients, populations. Next. Health workforce and the diversity we have in the racial and ethnic component, it doesn't reflect really what we are at this point in the United States. So health literacy is going to help us to increase the knowledge and understanding of diverse viewpoints and the misunderstandings that exist in communication when the patient and the provider have very different racial and ethnic backgrounds. The next one. This is a summary of whatever we have been living, and the data is from 2021, is a month old. The bottom line is that African Americans have had more deaths in proportion of their community for COVID-19, and Hispanic Latino more cases in proportion of wherever we are in the United States. Basically, health literacy is one of the main gaps that we have in the understanding of COVID-19, vaccination, and some prevention measures. Next one. Yes, the color of coronavirus has been all along that Black and brown communities. Next one. Here, I wanted to emphasize in the health workforce, because if we're looking in the latest data that we have in the National Center for Cultural Competence at Georgetown, 83.2% of registered nurses are non-Hispanic white. That is not the faces that we see in the United States, and less than 5% of physicians are Hispanic. So the health workforce composition played an important role in understanding culture and health literacy of diverse populations. Next one. I don't need to talk about bias, but we know that implicit and explicit plays an important role in the health literacy of our patients and providers. Next one. When we talk about discrimination, I want to emphasize just in the indirect part of this, because I have heard people on constant basis telling me that they treat everybody the same, everybody equal. Well, that somehow is an indirect discrimination, because if we're just using English with limited English proficient populations, the health literacy gap is going to be huge. So think about these issues that really are indirect discrimination, and there are topics for different conversations. The next one. And we can jump to the next one. Stigma. Stigma is another issue that is preventing people from increasing their health literacy skills. And I am part of a team working in the International Stigma Conference every year, if you're interested in more information about that. Next one. And then we go to the language and health literacy. Sometimes translators which work in written documents and interpreters which speak the language don't have enough health literacy skills to communicate with the level of the health literacy skills of the person that they are translating to. And these are pieces of the puzzle, next one, that I needed to mention, because that is what health literacy is all about. It's these cultural, cognitive, and social skills which determine the motivation and ability of individuals to gain access to understand and use health-related information. Let's stop here. Skill, it needs to be learned. We are not born with it. Motivation and ability. We are not trying to make everybody a doctor or a nurse. We need to increase that motivation that patients should have to ask about their illness or health, and the ability to navigate the system that is getting more and more complex. Next one, please. And that's the difference. In health education topic, people come, I'm telling you what is diabetes. But when we talk about health literacy, it's a multidimensional concept, as you can see from whatever I presented, and there are more layers on that onion that we don't have the time to talk about today. Next one. In addition to that, the demands and expectations of the system are totally disparate with the individual skills. We know how many changes CDC has sometimes every hour about COVID-19. It's impossible that people can catch up with all of these changes. So health literacy skills are going down and down in this context today. Next one. And that is health literacy. All these pieces of the puzzle, and it's everything and all the skills that people need to understand, maintain, and improve their health. Many, many more pieces of the puzzle that can be identified and add to this. The next one. And what are we doing that? If we see national statistics, 9 out of 10 adults have difficulty using everyday health information. CVS pharmacy health information. So every time you have 10 patients, maybe one is going to really understand whatever you're trying to convey about their health or illness. Next one. And I don't need to emphasize on that, but people need health literacy skills if they want to navigate the healthcare system, if we need the health history and everything that is pretending about their health. And go to the next one. Because the most important pieces are that when we talk about test results, people with low health literacy skills understand our words, but not the meaning of whatever we mean with that. And pamphlets, the same thing, discharge instructions. People has no clue many times of what do we mean with whatever we are telling them or putting in writing, which we know is not the most simple literature that we provide to patients. Next one. When we're talking about health literacy, the most important pieces that we need to understand is low health literacy people is always misinformed. It doesn't matter in the way we put it, the idea is not going to be captured because they cannot connect the lifestyle factors with the health outcomes. It's very difficult for them to connect the dots. So yes, they understand our words and sometimes they can repeat and teach back, but no understanding of whatever is the meaning of our maybe instructions to them to prevent some illnesses from coming or instructions for medication. Pretty simple. Next one. And that is very tragic because proficient is the green piece at the bottom of your screen. And in the Black and Hispanic community, just 2% or 4% of our population are proficient, the patients who really understand whatever we're saying, the veterans who can really follow up whatever they should be doing to preserve their health and prevent illnesses. Next one. And the public health professionals and healthcare providers, we are all on this to trying to improve the health literacy skills of the population. The next one. Again, I'm trying to emphasize that fact that is there, and just 12% of our US population is proficient. So for the rest of the community, the intermediate, sometimes 50% of the instructions are not going to be captured, even though they understand the reading, they don't understand the meaning. Next one. And that is one emphasis that we're trying to make here is health literacy is a silent epidemic and it's challenging the healthcare systems globally. So it's not just here, but we make it more difficult because our system is very, very much complex. The next one. And that's what happened. Everything we are, everything we know, our race, ethnicity, and age goes to whatever is health literacy and embody everything we have to access the healthcare system, to be able to converse with our providers in our self-care, and we end up with whatever is the health outcome. So low health literacy, very bad health outcomes. Next one. We know that everything that happened with poor health literacy is going to be a very bad outcome. But we need to emphasize in one other issue, which is a higher health cost. because people is going to come to the emergency rooms more frequently. They are going to confuse medication. They are going to come late and they don't use preventive services. Next one. One tremendous gap that we have is poor literacy. And poor literacy in the US is a drama. It really is. And when we're looking about these reports of the US Department of Education and National Center for Education Statistics, 18% of adults in the US perform at the lowest level of the international assessments, which is below level 1. Level 1 is below basics. So 18% of our population scores in literacy below basics. And we need to remember one thing: limited English proficiency, our new immigrant communities, they don't participate in these studies. So this is the pure US adult population that is several generations in the US to master the English language. Next one. It's just some resources. We can jump to the next one. Remember again, only 10% of adults have enough health literacy skills to navigate the system. And the next one. That's what is happening with the patients with low health literacy, as we expect. More times in the emergency room, more days in the hospital, cannot follow treatment plans, and of course, higher mortality rates. Next one. I would take like 30 seconds to talk about the National Hispanic Medical Association and the Fairfax County Health Department that is now starting a new program. It's a pilot program and health literacy related. It's called Stronger 2. And Stronger 2 is a 2-year program that's supposed to develop and implement health literacy plans that incorporate the national and cultural and linguistic appropriate service, appropriate standards class. And the goal is to develop these interventions and strategies that promote a change in the healthcare delivery system. So let's go to the next one. So what we're doing with this program basically is to ensure that a minimum of 310 healthcare providers can address health literacy barriers for patients, at least related to COVID-19 prevention, mitigation, and the resources and services. So basically, we are targeting all providers that are working with the Hispanic Latino populations. Majority of them are Black and Latinos, but everybody in the Fairfax County that is addressing and seeing Hispanic Latino populations. The next one. And this is a summary. The summary is trying to remember that health literacy is key to improve communication and understanding between patients and providers, and that health literacy is a silent epidemic. So we need to be very much alert of that. And the next one is just if there are some questions about that. Thank you.
Thank you. All of the speakers were great. And, you know, it's always nice to have speakers that don't say the same thing. And I have to say that everybody focused on a different aspect of communication. And Dr. Harmon, I'd like to ask you the first question, if you're there. And that is, how do you think physicians can communicate better, more clearly for low health literacy levels of veterans about, and I want to say about vaccines, because this is related to COVID-19 too?
Dr. Rios, good question. And clearly, many of our veteran community, and especially those who represent minorities and underrepresented in many other aspects of healthcare, are going to have some hesitancy. They have probably some understandable questions when the government and big organizations might offer and require concerns like vaccination. So I've had to address vaccine hesitancy in my patient population, among my veteran colleagues, among my military colleagues for sure. But what we have to do is establish trust to start with. And one of the things that the language document we talked about, and And I really, what I try to do is answer one-on-one when a veteran, when any patient is hesitant about a medication I might advise, or a treatment I might advise, or in today's world, immunizations, not only for COVID, for every immunization. I still have to push forward with a certain degree of forcefulness, the need for pneumococcal vaccinations, flu vaccinations, no question of it. And then we talked about, other speakers have talked about health literacy. I have to talk to them about colon cancer screening, breast cancer screening, and all these things. It's all about language. It's about establishing trust. I think what we need to do, we need to continue to understand that this needs to be a two-way street. We can't just be, this is the government, this is what's best for you. You're a veteran, you were used to taking military orders, and they couldn't question lawful orders and legal orders. But now, as veterans, they have a little more independence, and I think they want to be certain that we're addressing their needs with their needs in mind. Their patient-centered healthcare is what's important to me and all healthcare providers, especially in the AMA and the NHMA. I can't speak for Dr. Rios, but I promise you, I heard your presentation. You and I on the same page, Doctor. Thank you.
Definitely. Colton, let me ask you a question about your caregiving focus and the importance of communicating to low health literacy caregivers. You said that you should center around the lived experience of people. And what would you say to Latino or Latinx caregivers when you have your programs developed for skill building for those who are caregivers for our communities and our families?
Yeah, no, thank you for that question. And that's a great question. I think on the latter end of that, I think one thing I'll say is, and I think I challenge folks across the board, is we need more resources. We need more opportunities to help guide those conversations, help guide, caregivers from that community through the process, through that caregiving journey, and really helping provide them with the tools and resources that they may need so that they can feel empowered to have those conversations and really feel empowered to be included and know what to do when they're caring for their loved ones. And in our instances, caring for their veterans in their home as well. I think, and on the flip side, one thing that we're doing quite often is trying to really train providers and clinicians to recognize that, yes, the veteran and the patient is extremely important, and that is a priority, but also recognizing that when they leave, they are going home to somebody in a lot of instances. So making sure that we're having and bridging that dialogue with those caregivers who may not be in the room, but at least, providing that dialogue with the veteran or the patient, that recognizing that there are those folks and are those folks, because I think that will help bridge that dialogue. It is a two-way street for that more collaborative and communicative care team, but we need to do a better job. And we at the foundation really also is advocating for a better job to providing caregivers on all sides and the providers and the clinicians with the tools necessary so that communication can be more common, more fluid, and just easier. And whether that be in multi-language tools, multi-language resources, we really need to do a better job. And I think across the board, hopefully other organizations are coming to that challenge. And it sounds like obviously the folks on this call are, but I think hopefully others that will tune in can join us, to making sure that's a priority and a focus area. So. Yeah,
thank you. I very good answer there. Let me say to Dr. Vargas, one of the questions that came up was really about tools to actually assess the services that providers provide to their patients. Do you have any referral to tools? I know you mentioned the CDC, but tools to assess the availability of the services that providers have, and especially cultural competence tools or practices that providers can use specifically, for the Latinx patient population?
Yeah, we have several tools, not just for knowing about cultural competence, but even to assess the health literacy skills of their patient population, because that is key. Without assessing, we don't know exactly the level of health literacy that we need to start communicating with patients. So Office of Minority Health has a series of validated tools. CDC has a series of validated tools. There are trainings about validated tools and how to use them. There are validated tools that we can use in 3 to 5 minutes, like if it's in an emergency room. We don't have the time to start scoring people. And there are validated tools that we need to use, like in Veterans Affairs, if we're talking with a person for 40 minutes or so, that take us 15, 20 minutes to assess. And normally it's recommended to do it like every year, because the health literacy skills of people may increase or decrease with the time. I mean, there may be other diseases that decrease the health literacy skills and understanding of some people, veterans, when they start being senior citizens or so. And some people start learning more about their illnesses and diseases, so the health literacy skills in that topic increases. But Office of Minority Health has several of them that they are free. And so CDC, there are some other tools available, because we have about probably 200 validated tools to assess health literacy skills. And some of them, obviously, universities have developed, and there is a cost to start using them in 1,000 patients or something like that, that they are very good. They are more kind of illness oriented. So if you have a group of people with a particular illness, may be very helpful.
Another question for you, there specifically, are there certain websites that you can provide right now? But I think maybe what we can do is offer to all the people that are registered for this call that we would send references that I know Dr. Vargas has developed. And also our National Hispanic Medical Association has a new website called hispanichealth.info that has information in English and Spanish for providers and for patients to learn some basic information about certain diseases like COVID-19 and others. But is there a specific website that you can provide to people about health literacy tools?
Georgetown, the Center for Health Literacy, just have a series of tools that they are easy to access, and at the same time they are free, because they develop everything with federal funding. So it's for everybody to just grab them and use them. My recommendation is to take some training. There are so many free trainings in how to use it, because then it facilitates the process of how do I score that? What is the tool that I should be using? What is the correspondent in Spanish that I can use very easy because I have the English version, et cetera, et cetera. So, and there are many trainings that CDC, NIH, and universities, and probably the trainings that we will start, Dr. Rios, about health literacy can be recommended to many providers that would like to take them, because I think the second phase could be basically about tools, which is a question, not only tools, but how to make health literacy real, which is a CDC program, because learning about the tools and now how do I do with that?
Somebody else mentioned the importance of toolkits. Yeah, and let me just say, someone else mentioned the importance of toolkits, and NHMA has a toolkit that we have been developing, and we will have that on hispanichealth.info soon. Let me ask Dr. Harmon a question about veterans. Again, how do you deal with disabled veterans? Many disabled veterans that need extra, extra skills for their healthcare providers and caregivers. And maybe Colton, you want to talk about that too. But it's just the idea that, and not only disabled veterans, but veterans going through PTSD. There are very, very strong behavior, communication, lessons that you need to talk to caregivers and patients and their families about that are very unique to veterans. Dr. Harmon first.
Dr. Rios, and I won't take too much time, because that, to your point, and others on the call, we have such a complicated answer that it would take the hours to come up with formulated responses. But clearly, mobility issues. Let's say when we say disabled veterans, I'm talking about patients with mobility issues, that mobility impaired. We have taken at the AMA, not just the veterans community, but have taken a new focus on mobility impaired patients, not only mobility impaired patients, but all physicians have mobility impairments too. So we have to address the needs of mobility impaired caregivers, patients, and providers across the spectrum. This has been, in my opinion, underaddressed historically. We typically, as physicians, don't always think that way. We have to think that when we ask our patients to show up for a various appointment or get a procedure done, you have to think, is this person mobility impaired? Can they get inside the MRI unit? Can they simply get to the pharmacy? How do they get their medications delivered to them? If they're mobility impaired, they're dependent upon someone to drive them there. All these questions that the average physician sometimes doesn't think about. And there's a high percentage of this in our veteran patient community as well. No question of it. And finally, when you talk about PTSD, I talk about behavioral issues, behavioral health issues, particularly mental health issues that have unfortunately had a stigma approach assigned to them forever. And our veterans, even when they were in the military, were told, get back into the fight. You may be undergoing battle fatigue or stress, but you're not allowed to express your concerns. And some of these folks would suppress it till they returned from the combat arena, became active in their civilian non-combat arena, and they had difficulty readjusting. All of that leads to the PTSD that we're now seeing for decades. So we have to destigmatize it, not only in the veterans community, but in others, but particularly in the veterans community, because that is key to many of our veterans' health issues. Destigmatize, improved access to substance use disorder care and other behavioral health issues, and address what we call mental health parity, so that those that are seeking care, those providing that care, have parity in payment and recognition of the medical needs for these patients, and particularly for the veteran patients. Long-winded answer, but a very serious question. Thank you.
Thank you.
Yeah, and I'll just pinpoint Dr. Harmon took most of the words out of my mouth, but yeah, the recognition that, the visible wounds and the invisible wounds are both so equally important when addressing this community at large, and even pinpointing, as you were mentioning, the mental health aspects of not only the veteran, but it often sometimes does translate into, as from some of our research, the caregivers as well. So recognizing that it is so much more complex than what you just may see with your own eyes. And so I think recognizing that is so important. And then also, as I mentioned before, is making sure caregivers are a part of that conversation early on, because they are able to provide some of that information or knowledge, or even help, the patient or the veteran get to those units that you were mentioning. They may not even recognize that they would be able to go to, or a situation that may have happened the night before that the caregiver remembers. But in the particular appointment isn't translated to the provider or the staff. So just being mindful that it is that complex issue. It is invisible and visible, and the important aspect to addressing all of it is so vital. So definitely well said, Dr. Harmon.
Good. One last question. I serve on the Veterans Administration's National Academic Affiliation Council, and the VA teaches medical students and residents on how to take care of veterans within hospitals and also outpatient clinics across the country. Dr. Vargas, a question came up. If you were teaching a young medical student how to use cultural competence and health literacy, what would you tell them when they see their first patient and let's just say that the medical student is a white person who never saw a Hispanic in their community or never saw a Black person in their community, and wanted to be respectful, wanted to learn how to approach their first patient?
So it's pretty much what we teach to every medical student about vital signs. You don't need to even understand what is it. Take the vital signs, and you will learn the temperature of your patient and the blood pressure and how much the patient weighs. Exactly the same thing. We need to continue with the issue of health literacy. So there are different tools that we can use for that, and people has to know them. The easiest ones are like even with a label of a product and very simple 2 questions, we start understanding the gaps that we have in front of that person or not. and then start asking about their cultural values in the way that is easy to comprehend, because we don't know. I mean, it can be another white person, but with different cultural values. So understanding that, should I address you by your first name, or you prefer your last name? Hey, hello. Okay, Mrs. Sanchez, how are you doing then? And what is the way that we should proceed? Do you want really your husband being with us? Well, I examined you. You start learning some of the most important cultural values that people has, and then at the end, depending upon how people is in front of you, you keep assessing throughout the first visit. And that's what we teach in Howard University Medical School, that after that is like you're going to tell people just 2 things at the end of the first visit, just 2, because if you give it 5 instructions, they are not going to remember 1. They are going to confuse all of them. So it's limit whatever you want to tell them. You got to come back in a month, and that is for the lab. Lab is in the first floor. Fine. That is as much as I can go initially with everybody. So people doesn't need to really start looking if their race or ethnicity is compatible, if they go and they assess the culture of everybody. We have seen now with COVID and everything that there are so many different views in the white community about different issues. I'm not going to be vaccinated. My right is to don't wear a mask. My right is to wear a mask. So cultural values are diverse. And yes, if we add race, ethnicity, and language barriers, then we create the perfect storm. So you need to go step by step. It's doable. People is doing it. So if somebody needs a little bit of advice, there are so many trainings about how to assess cultural and health literacy skill. Remember the other vital signs.
Okay. Well, I think that's going to conclude the discussion right now, but we do have some polls in our staff. Vincent and Michael, were you going to show polls? I think they want me to say the program update for the next program. Oh, here they are. Here's the polls. This is a health literacy, just a couple questions. If you all can go ahead and answer. According to the U.S. Department of Health and Human Services, what is the percentage of U.S. population that is health literacy proficient? Please choose one. We will be able to see answers. If everybody can go ahead and choose one. I'm just going to wait a few seconds. Okay. Vincent, do you want to show that? Or do you want me to go to the next one?
They're showing in real time.
You're showing it? I don't see it. Let me go to the next one. Let's go ahead and answer the next one. Low health literacy is associated with higher mortality rates, lower levels of health knowledge, greater use of inpatient emergency departments, and poor medicine adherence. And the last answer is B and D. And everybody is supposed to just choose one. Vincent, do you want to show the results?
The results are coming in real time. So they're being shown.
I cannot see them, Vincent.
Yeah, we can't see them. We can only see the question with the choice of answers.
Okay, so once we go through all of them,
results of the poll.
once we go through all of them, I think it'll allow me to show it.
Okay, I don't know how many there are. I only see 2. We went through the 2, Vincent. Is there a number 3? Okay, so this is the 12%, and got the best answer there about the health literacy proficient, and for low health literacy associated with higher mortality rates and lower levels of health knowledge. Dr. Vargas, do you want to tell us if these questions are correct?
Yeah, I think most of the audience have been paying attention to that, because just 12% is the perfect answer. And as for
Okay.
the next one is just all of the above, because everything is altered with people with low health literacy. And I think they were answering the third and the fourth. And the issue, if we can tell actually, if a health literacy person, depending upon their school grades, and the answer that is false, because many people who not only finish the school but is in college have very poor health literacy skills. And is health literacy linked to cultural
Oh,
beliefs?
there it
And
is.
so,
Okay.
yes, and I think that is correct. So thank you everybody for paying attention to whatever I was mentioning.
Yeah, thank you. And I didn't realize I had to push that down with the arrow. So I didn't see them, Vincent, sorry. Anyway, thank you very much for that. Our NHMA program update, just for everybody to know, this session, our COVID-19 vaccine webinar will not be happening in February or March. We're going to wait till April, the last Wednesday of the month in April. Right now we have a vaccination for all campaign. We ask everybody to go to our vaccinateforall.org website or our hispanichealth.info to be able to become a champion and help us spread the word through our social media messages. We also have, again, our COVID-19 webinars. We're looking for speakers. And we also have this speaking opportunities with the construction company called DPR around the country in the major markets where Hispanic patients are. We are asking for some bilingual Spanish speaking doctors who would like to be paid a couple $1,000 stipends for speaking to the workers and their families. And these events will probably be on Saturdays. We're looking for those people now. You can send them to vgarrity@nhmamd.org. His email is at the bottom of the screen. We also have some small grants for doctors, dentists, nurses, and community-based organizations in Oakland, Houston, and Chicago. We are working with the Congress offices in those cities, and we're actually mailing and distributing 50,000 books to grammar schools. And just like Dr. Harmon mentioned with the AMA, we're going to have our own Dr. Back to School program, but just to convince grammar school kids, parents, and PTAs to get vaccinated against COVID-19. In the books that we have are cartoon books in English and Spanish, so that the kids can go talk to their grandparents and their parents about the importance of getting a vaccine. And then lastly, we have a Hispanic Leadership Development Fellowship with HACU, the Hispanic Association of Colleges and Universities. We're funded by the Office of Minority Health to find graduate students, especially those with a master's in public health or behavioral health or political science, who would like to come for a year, a paid year leadership program, fellowship program. NHMA will have mentors who are within HHS, and you will be working at offices at HHS, and hopefully the success of this program will be how many of these students we can get jobs for and keep them at HHS. Again, send your interest to vgarrity@nhmamd.org. Is there another slide, Vincent? And again, our national conference is coming up March 24th through the 27th at the Crystal Gateway Marriott in Crystal City or Arlington, Virginia. And you can visit nhmamd.org 2022-conference for registration. And we are also still taking poster abstracts. And like I said, our next virtual briefing will be in April. And we are going to have topics ranging from mental health impact of COVID and any updates on any more vaccine variants, and of course, children and the vaccinations and other issues as we get speakers. So if you'd like to be a speaker, again, let us know. And we're very thankful to all our speakers, especially Dr. Harmon, Colton, and Rebecca for being here today. And I want to thank our staff and thank NHMA for putting this on, and CDC for supporting us in these series of educational forums. So with that, I'm gonna close and thank you all very much for sticking with us tonight. Thank you.